Every year, millions go under the knife and walk out completely fine. But there is a hidden, specialized tier of medicine where survival is genuinely a coin flip. These are procedures where a patient's heart is stopped on purpose. A single millimeter slip means paralysis, and surgeries exceed 24 hours. Surgical danger represents the absolute limit of what the human body can endure and still recover. It is the ultimate test of biological capacity. What specific physiological and logistical variables escalate a medical procedure into a life or death gamble? Surgical danger is never random bad luck. It is a strict, measurable formula of escalating physical risks that medical teams must meticulously map out and manage. Statistically, the single deadliest common surgery performed today is thoracic aortic dissection repair, which carries a staggering mortality rate between 20 and 30%. This diagram of an aorta illustrates the mechanical failure driving the emergency. A sharp tear forms on the innermost wall. High-pressure blood immediately forces its way between the vessel layers. The resulting outward bulge can cause a fatal rupture within minutes. To counter this rapid deterioration, surgeons deploy an extreme tactic. They halt the patient's blood flow and cool their entire body down to slow their metabolism, protecting the brain from oxygen deprivation. When a sudden emergency removes the time needed to plan, surgeons are forced to artificially induce a state of near death just to keep the patient alive. Moving from sudden emergencies to scheduled operations, the heart-lung transplant represents the peak of biological complexity. This schematic of a cardiopulmonary bypass machine shows how the procedure is even possible. By entirely disconnecting a person's failing core organs, the surgical team routes the patient's blood into that central reservoir and oxygenator column, relying entirely on the machine for circulation and oxygenation. This diagram shows the Whipple procedure's complexity. Cut points separate the stomach, pancreas, and small intestine. The true risk is the rebuild. If one connection leaks a millimeter, digestive enzymes eat surrounding tissue from the inside out. Structural complexity is defined by the rebuild. Surgeons must flawlessly reconnect the body's plumbing to prevent digestive enzymes from turning against the patient during recovery. Neurosurgery introduces the ultimate test of precision. Because brain tissue doesn't regenerate, margins of error are measured in fractions of a millimeter. To maintain that exactness, patients are secured in heavy metal surgical frames to eliminate even microscopic physical movements. The margins are so tight that patients are often kept wide awake during the operation. By having them talk or move their hands, the surgical team gets real-time feedback, ensuring irreplaceable speech and motor regions haven't been disturbed. Physical endurance becomes a variable during procedures like the separation of conjoined twins, where teams must meticulously isolate shared structures, such as a major blood vessel at the base of the skull. These marathon procedures can stretch well past 24 hours. A tired surgeon is a dangerous surgeon, which is why entire relay teams rotate in coordinated shifts to maintain peak stamina. To manage human limitations, surgical teams are leaning into advanced imaging, AI risk analysis, and 3D digital rehearsals to shrink the gap of physical error. Robotic-assisted systems now allow for sub-millimeter movements that the human hand simply cannot physically achieve on its own. As medical procedures hit the absolute physical limits of human endurance and manual precision, technology steps in to extend the surgeon's capabilities. All of this raises an essential question. Why would any patient or doctor willingly step into such a brutal, high-stakes environment? The reality is that conditions like a torn aorta, failing lungs, or untreated pancreatic cancer all share the exact same outcome, a 100% certainty of death. In these highly specific scenarios, deciding to do nothing is statistically the most dangerous choice a patient can make. The surgeons who specialize in these procedures are not reckless gamblers. They are highly trained executors of rehearsed, meticulously calculated risk. Surviving one of the world's most dangerous surgeries isn't a stroke of luck. It is the result of decades of medical evolution and a synchronized team willing to stand at the edge of biological failure and pull the patient back.